alaikum wa rahmatullahi wa barakatuh, IMANA community. You're hearing a very unfamiliar voice this evening. Many of you are used to Dr. Amber Khan, who is chair of IMANA's Education Committee. She unfortunately cannot be with us this evening, although we will miss her. My name is Nida Salim, and I am the executive director at IMANA. I'm very excited to join you this evening for this wonderful presentation for this month. So this month's webinar, we have Dr. Azeem Elahi, who I'm very honored to introduce. Dr. Elahi is both an IMANA board member and an Aid Gaza medical team member. In addition, Dr. Elahi is esteemed as a physician specializing in pulmonary and critical care medicine. He's always been known for his exceptional clinical skills and compassionate approach. Dr. Elahi is highly regarded within the medical community and cherished by his patients. He's always valued collaboration among healthcare professionals and advocates for a team-based approach to patient care. So collectively today, we'll be learning from him about smoking, e-cigarettes, and vape-related lung disease. It's a topic that should be of importance to all of us, something that we see as a growing trend with vape shops on every corner that we turn, with significant societal impact. So with that, Dr. Elahi, I'm going to hand the mic over to you. Welcome, and thank you for your presentation this evening.
Assalamu alaikum, Nida. Thanks so much for that introduction and for inviting me to speak about this topic. I agree. I think this is so important, not only for our own communities, but just as a general health-related issue that many of us and many of our family members face. What we're going to talk about today is smoking, e-cigarette, and vape-related lung diseases, but we'll be emphasizing some time on strategies to help quit, because I think that's what's important, and oftentimes it's not something we talk about. The content from this lecture comes from the U.S. Food and Drug Administration, some of the data, a lot of it also from the Centers for Disease Control and Prevention, which keep track of a lot of the key data marks for these kind of public health issues. The knowledge base is quite vast if you hop on to the American Lung Association website. And I happen to be on the board for the North Carolina chapter of the American Lung Association as well. And then I think it was 2 or 3 years ago, we had a shared event where we also had speakers from the Campaign for Tobacco-Free Kids. And as you'll see as we go through the lecture today, I think we'll need to really emphasize some strategies and awareness surrounding tobacco use and nicotine use by our younger population. So with that, here's our outline. We'll review some statistics because without that, I think it's really hard to understand the impact and the outcomes associated with certain health issues. We'll review tobacco products and electronic devices that deliver some of these chemicals. And then I've got consequences in bold because I do want to emphasize some of that. Review the symptoms associated with lung diseases in general. And I've also emphasized tobacco and nicotine cessation because, like I said, I do want to spend a little bit more time on different strategies we have to help everyone potentially quit smoking who's interested. And at the bottom, some risk mitigation strategies for people who we already know have a history of smoking and are looking to improve their health. So some statistics. When we look at the general population in the United States, we have more than 16 million Americans who live with a disease that's caused by smoking. And when you consider this, cigarette smoking being the leading preventable cause of disease, death, and disability in the United States. Cigarette smoking and secondhand smoke exposure cause more than 480,000 deaths each year in the United States. So to me, that's alarming. And obviously it huge area of health concern. Cigarette smoking harms nearly every organ of the body. It causes many diseases and reduces the health of people who smoke. The cigarette smoking also increases healthcare utilization, healthcare costs, and absenteeism from work. So those are obviously implications for our societal gain. And when you look at this list of the disease states that smoking causes, it's just so vast. Cancer, lung cancer especially, 25 times higher in patients who smoke than don't smoke. Heart disease is 2 to 4 times higher in smokers, and stroke is 2 to 4 times higher in smokers. Oftentimes a consequence of long-term smoking are other lung diseases such as chronic obstructive pulmonary disease and emphysema. We have complications due to type 2 diabetes, harmful reproductive effects, and other diseases, including eye disease and problems of the immune system. Cigarette smoking increases the risk of death from all causes in both men and women. Now, we've known for years that smoking causes lung cancers, and that's still true today, where nearly 9 out of 10 lung cancers are caused by smoking cigarettes. But what's especially relevant in this day and age is that smokers have a greater risk of lung cancer today than even 50 or 60 years ago. And one reason that's postulated is that the cigarettes are just made up of different chemicals now than ever before. In addition, smokeless tobacco, such as chewing tobacco, also causes cancer, including the esophagus, mouth, throat, and pancreas. And what you can see in this infographic from CDC is the implications from head to toe where cancer is increased in our smoking population. Beyond smoking, we have secondhand smoke that so many of us are exposed to, and it's particularly harmful. This secondhand smoke exposure contributes to over 40,000 deaths among non-smoking adults and 400 deaths in infants each year. In adults, secondhand smoke can cause coronary heart disease, stroke, and lung cancer, as mentioned. And children exposed to secondhand smoke are at increased risk for respiratory infections, ear infections, asthma attacks, and sudden infant death syndrome. In the United States, more than 8,000 non-smokers die each year from lung cancer as a result of secondhand smoke. So with that background, raising this on our list of healthcare emergencies that we need to be aware of, I think it's important for us, especially as adults, as leaders in the community, potentially, as parents, as siblings, that we understand what's out there. What are we all exposed to, and what are our children exposed to? So this is sort of a broad look at the different types of tobacco products that are out there. And you see cigarettes, you see smokeless products that includes chew tobacco and something called snuff or snus, which is a liquid form. There's cigars, there's pipe tobacco. You see hookah here and cigarillos, which are kind of thin cigars. And then you see the electronic devices such as e-cigarettes on the end there. And for whatever reason, through all of mankind, tobacco products have just been manipulated in any which way and ingested by being smoked or heated or chewed or absorbed or dissolved or inhaled or ingested. It's just that components within it is that nicotine is so highly addictive and toxic. It's just made it so that all of these products have developed such broad methods of ingestion. Now, we know as the general public how toxic cigarettes are. In fact, anytime somebody buys a pack of cigarettes, it's mandated now on the box, on the carton, to list the harmful effects of cigarettes. But when you look at the chemical compounds that exist in cigarette smoke, it's alarming. There's over 7,000 different chemical compounds in cigarette smoke, and 70 of these compounds have confirmed carcinogenic activity. And those are listed in this infographic. So we know with strong scientific evidence the link between this consumption and the development of various cancers. Now, when we look into the different consequences of the inhalation of smoke and these products, if we start looking at the left panel, which demonstrates healthy lungs and healthy alveoli, which are the sacs through which our lungs bring air and oxygen in and dissolve that oxygen across those little membranes that you see, the little round balls there. And that's how it gets into the bloodstream, because these little sacs are coated by blood vessels. And when you're inhaling this toxic smoke, the harmful particles get trapped in those sacs, and it triggers this inflammatory response. And what ends up happening is the inflammatory chemicals, they actually dissolve the walls within these sacs. And so you then form this large air cavity that's lined by this carbon deposition. And that's when, anytime you see a gross anatomy of what lungs look like in a patient who had a smoking history, it's why you'll see all of that black sort of soot, the black appearance on the lungs from all of that carbon damage. On this panel here, chronic obstructive pulmonary really is this sort of umbrella term used to describe progressive lung disease. And it starts off with chronic bronchitis and can lead to emphysema and COPD. And this is the pattern of COPD, emphysema, I'm sorry, that I described. But what you look at over here are the airways that bring air in and out of your lungs. And in smokers, what we see is this development of excess lining inflammation, and makes it more thickened and coarse. We see excess mucus that forms. And in sort of the consequence of all of that is that instead of having this nice round pipe to move air in and out of, you've now developed this narrow airway, what makes it much more difficult to move air in, and consequently also exchange and expel air out. And that's what leads to some of the symptoms associated with these lung diseases that we'll talk about in a little bit. Beyond the lungs, however, there are adverse consequences to your heart, and in addition to that, your circulation system. So the chemicals you inhale actually damage your heart and the blood vessels, and these make it more likely for you to develop atherosclerosis, which is the fancy word for plaque. And that's what you're seeing here, this sort of yellow lining that's occluding or narrowing the actual blood vessel lumen, or the canal where blood is meant to circulate. You can see is cut narrowly in half, or even on this side in the lower legs, you see it kind of cut narrowly into maybe a quarter of what the normal blood flow should be. So as plaque builds up in the arteries, it makes it much more difficult to perfuse or circulate blood flow, which is what's transporting the oxygen you breathe to vital organs in your body. So any amount of smoking, even occasional smoking, causes this damage to the heart and vessels. And it sometimes is that even certain populations are even higher risk of developing this damage. People who, women who are on birth control, for example, people who have diabetes are a particular higher risk of developing some of this. If you have high blood cholesterol levels, if you have high blood pressure, if you have excess weight or obesity, or being overweight, these are other predisposing risk factors that put you at even higher risk of developing atherosclerosis, or these plaques in the blood vessels. Now, the consequence to this are heart attacks, as we discussed, and in the lower extremities, the legs, for example, when you can't provide adequate blood flow to your legs, the main organs, limbs that you have for mobility, you're unable to then to provide adequate oxygen and circulation. And so this is when a lot of our older patients, middle-aged patients that have high degree of plaque, start developing cramps or pain when they start walking. And it's that same sort of heart attack pain. Instead of in the chest, they feel it in the legs because of inadequate blood supply. Now, we see this damage even in patients who are exposed to secondhand smoke. So obviously you've heard me say that now more than once. The consequence of smoking is not just to the end consumer, the end user, it's also to people who are exposed to that secondhand smoke. And oftentimes it's family members, it's children, it's people who are in that shared environment. Now, with all that being said, when you look at the data that surrounds um, adults who smoke, and this is a table of 1944 to 2021, a Gallup survey. And what you see on the x-axis, the bottom line here, is the year, and this goes from 1941 all the way up to 1945, sorry, all the way up to 1921. And on the y-axis up here, going upwards, is the percentage of people who said yes. And essentially what you're seeing is from the 1950s all the way up to year 2021, you're seeing this downward trend. So statistically, actually, as US adults, we're actually, as a general population, smoking cigarettes less. Now, when you look even deeper into that, what you also identify are in the age groups of people who are still smoking somewhat higher amounts. It's the middle age, younger age cohort. So age 25 to 44 represent about 14% of the higher smoking population, and age 45 to 64-year-olds represents about 15%. And the lowest percentage of smokers are in our younger range from 18 to 24. This graph here, similar year span on the bottom, but now we've split it up into people who reported smoking less than one pack in the green line, people who reported smoking one pack in the blue line, and in this dashed line, people smoking more than one pack. And what you see is a trend towards people smoking less heavily and more people smoking less than one pack per day. So even though the overall trend, people are smoking less, amongst those people who are smoking, they're also smoking less cigarettes per day. That's what this graph indicates. Now, we're going to kind of change focus from cigarettes now to e-cigarettes. And essentially, these are termed electronic nicotine devices. And what you can see here is such a broad range of what these devices are. You can see e-cigarettes, you can see vape devices, you can see Juul devices. You can see all of these devices are electronic based, and they have a liquid, and they form this sort of aerosol, and that's what we often see in people who use it. So it's such a colorful collection of items, and that's what we'll discuss about in just a short couple minutes, why it's become so particularly troubling in our younger population. So essentially all tobacco products, including e-cigarettes, contain nicotine, but not all of these e-cigarette devices actually contain nicotine. So all e-cigarettes contain nicotine, but not all e-cigarettes contain, maybe I said that incorrectly. Not all of these devices actually have tobacco product or nicotine. Some of these are just actual vape devices with that liquid, and that's what you're inhaling rather than a nicotine item. So this graphic represents it demonstrates the percentage of middle and high school students who currently use e-cigarettes or any tobacco product from 2011 to 2018. And there's a couple marks that you'll notice on here. One at this 2013, so they're kind of separated into high school cohorts and middle school cohorts, and that's the black line versus the blue line. But what you'll see is sort of this trend right around 2013 where you see an upward trend. And then again, right around 2017, you see this very sharp incline. And based on the data that's presented, by 2014, right around here, e-cigarettes were actually the most commonly used tobacco products among US youth. And it's particularly troubling because these devices, the e-cigarette devices, they're typically bridge devices that lead our youth onwards to smoking other products, cigarettes or marijuana, for example. The rise that you see here in 2017 really corresponds to the 2017, 2018 era when the popularity of these sort of USB flash drive tech devices, the most sort of commonly labeled Juul device that you see here, came to market. And I think that did cause a fair bit of increase in popularity amongst our youth. They can be used discreetly, unfortunately. They're oftentimes quite compact, and so it makes it very easy to hide them. And what's scary is that they actually have quite a high nicotine content. So the liquid within it is a nicotine salt. And then they're flavored, and that's what's made it so much more of a marketing material for these companies. And then you'll see these slogans. It's cool to Juul. That's really appealing to our younger cohort. This graph demonstrates essentially the predominant type of tobacco product now. And what you see here, obviously, is e-cigarettes are the largest representation here of 20.8%. And this is in our younger population, again, under 18. Cigarettes are 8.1, cigars are 7.6, and everything else sort of falls below that. But e-cigarettes are 1/5 of that cohort. 3 out of 10, so about 30% of teens who vape go on to smoking in the following 6 months. So let that sink in for you all. When we see this vapor that comes out, we think of it as, something benign, but it's certainly not. It's not water vapor that you see when people are smoking or using these devices. The e-cigarette aerosol is actually quite dangerous. There are several chemicals that are dangerous that are emitted from that vapor. What we find are a whole slew of metals that are detected within that vapor that our colleagues and friends and family are inhaling. And then there's known carcinogens that are detected in urine of users of vape devices, and these are a few of them here. And it develops this dependence in similar ways to smoking, where you have cravings and withdrawal symptoms that lead to a lot of irritability or insomnia and depression type symptoms. So it's quite worrisome in similar ways to smoking cigarettes. The harmful effects have huge implications, not only on the pulmonary side of things with the lungs, but also on the cardiac side of things. And you can see both short-term and long-term damage as a consequence of these e-cigarette aerosols. This is a schematic just showing some of the symptoms to be alert for. When you look at patients, or if you are the patient, you want to be aware of certain symptoms because a lot of these things are often downplayed, and these symptoms can progress. And what's ideal when you are exposed to tobacco smoke, when you're exposed to e-cigarette or vape products, you want to identify issues early, not late. So keep an eye out for a cough that persists or even potentially causes you to cough up some blood. Keep aware of any sort of chest pain, especially if you're exerting yourself and that causes episodic chest pain. Be aware of feeling short of breath. It's not because someone's getting older. We have plenty of 70, 80-year-old patients who get around and walk around for hours and do just fine. So if there's shortness of breath, don't downplay it because of age, or there must be something for us to investigate. If you detect wheezing, fatigue, unexplained weight loss, these are all reasons to really get checked out by a healthcare professional. So sometimes what you hear or what you think is that it's just too late to quit. I've already done damage. What's the point of quitting? And here's where I do want to spend more time on emphasizing what the benefits of quitting are and some strategies for you all to help quit. So it's one of the most important actions one can take to improve their health. It improves your health and reduces the risk of premature death by quitting. It also reduces the risk for smoking-related diseases like we've talked about already, heart disease, cancer, and COPD. And what's pretty remarkable, subhanAllah, within 12 hours in somebody who has quit smoking, your carbon monoxide levels actually drop to normal levels. Within 2 weeks to 2 to 3 months, your risk of heart attack begins to drop and your lung function improves. At 1 to 9 months, your coughing and shortness of breath actually improves. At 1 year, your added risk of coronary disease is half that of what it was a year prior. And at 5 years, your risk of stroke is reduced to that of someone who never smoked at all. And at 10 years, your risk of dying from lung cancer has already been cut in half of that of a smoker. And by 15 years, your risk of coronary heart disease is the same as that of a non-smoker. So clearly, the reason why there's such public health initiatives to educate the community about these harmful effects of tobacco and electronic nicotine devices, it has huge implications when we're able to successfully quit. And so we're vested as lung doctors, as tobacco cessation specialists, as your primary care team to help you, guide you through the steps it takes to help you quit. So what are some of those options? Well, the Quitline is one that I actually use quite a lot with my patients. One, it's essentially nationwide, and it's a free resource from every state in the United States. So if you were to call 1-800-QUIT-NOW, what they'll help you do is create a plan, discuss available medications, and offer access to some of the free tools that we'll actually go through. But what they provide is free coaching over the phone. And that coaching helps you ultimately quit smoking when you come up with this plan together and when your mindset is at a point where you're ready to quit. So when you call, you actually speak confidentially with a highly trained quit coach. Some of these coaches have actually been smokers themselves, so they have firsthand experience dealing with a lot of what you might be experiencing yourself. They understand what you're going through as a result of that experience themselves. And they're all trained really to be good listeners. Sometimes we just need somebody to hear us, identify some of our triggers, and give us some helpful tips that help guide us away from succumbing to the cravings that might be there. They'll also sort of ask you questions. What is it that, what your habits are? What is it that leads you to smoking? What are you interested in? Because we're also trying to identify what are areas that you want to get back to. What have you lost, and what are you trying to regain by improving your health? A lot of people have already tried quitting in the past, and then they think, all right, well, I failed once, and they're ashamed of that, and they're disappointed at that. But it oftentimes takes 2 or 3 or 4 attempts finally to quit. And so there's nothing to be ashamed about when you're thinking about improving your health. And I think that's very important that you use that experience and actually build upon it. So I'm going to kind of move on to the next slide, which goes through some of the apps that are available, because I think in this day and age, almost all of us have a device in our hands. And with its access so immediate, these Quick Start apps, this one example is provided and created by the CDC, is a very effective tool that helps you track your cravings. And when you are craving, being able to interact with the app itself to create some distractions, create some different options that you might have that might have steered you that might steer you away from succumbing to that craving. So this is a free app called Quit Start, and that's available to download on any device. This is what the screens look like. On the right panel, you'll see some tips, because I think sometimes we just need some, reassuring, unbiased, unjudgmental information or help from somebody, even just a device app like this. So those are some of the non-pharmacologic strategies, but obviously there are chemical dependencies that exist in people who smoke. And I think when you're looking at strategies to help you quit, it's really important for you to combine strategies. So what we do see in patients who are successful in quitting is that there's no one recipe for everyone. Everyone is unique, and you have to find a recipe that works for each individual. But most of the time, it's oftentimes some type of combination that's most effective to help our patients quit. So the medications you'll see, there's really 7 main products that you see that are available to help patients with quitting. Chantix is one of the medications that requires a prescription, as is bupropion. And then the nicotine replacement helps with the nicotine dependence aspect of it and the cravings. And that's where the patches or the gum or the lozenges. They also have nasal spray and inhaler, and we'll go through each of these in a little bit more detail. And what's fortunate is most health plans actually cover these FDA-approved medications to help you quit. And some of the nicotine replacement products are actually even accessible without prescription, so you're able to receive those without significant barriers. When you call that 1-800-QUIT now, they actually are able to provide some of the nicotine replacement and the nicotine through the patches or the lozenges or the gums. They can also potentially provide that to you free of cost if you don't have insurance. So this is how Chantix or varenicline works. When you smoke a cigarette, there's a reward center in the brain, and that becomes activated and it triggers that reward response, which is dopamine, and it makes you feel good because of that. So your brain cells have these nicotine, the nicotine actually binds onto these receptors. And so when you're not smoking, the nicotine receptors are lonely. They're not bound by any of the ingested nicotine. And so there's less dopamine that's circulating in your brain. And so what happens then is that with less dopamine release, you start feeling down, you feel like you have withdrawal symptoms, and that's when these cravings come on. So varenicline or Chantix actually blocks those binding sites. And as a result of that blockage, you have a sort of a normal level of circulating dopamine. And so it helps sort of blunt that the abnormal or depressing craving type feelings that you have when you're not smoking or when you're trying to quit. The nicotine replacement therapies, the patches, what you essentially do, they come in 3 different doses, and based on how much you smoke, you'll start off at the higher dose and then you eventually wean down to a lower dose, and that you finally get down to the lowest dose. And so you're essentially weaning yourself down from one dose to the lower dose to the least dose so that you can successfully quit smoking altogether. The gums are there because they act more rapidly compared to a patch. So oftentimes patches and gums or lozenges are used in combination because the patches just give you sort of a baseline amount of nicotine. And then if you have a craving and you're having a hard time overcoming that, you can actually put that gum in your mouth. Now, this gum is not a chewing gum. It does look like that. And so some people try to use it, and then it's got this very peppery, nasty flavor to it. But you're actually just supposed to chew it once, and then you leave it in the pocket of your mouth, so right between your gums and your cheek, and you let that sort of seep out. And then once that flavor is gone, you can chew it one more time, and then you let it just soak there. And eventually, all of that flavor dissipates. But that's what helps with the acute cravings, the acute nicotine ingestion. The lozenges work in a similar way, as does the nasal spray and the inhalers. And like I said, everyone needs it. There's no one recipe for all. And so that's why there's such a broad range of different medications here. So aside from quitting smoking, there are other strategies to help mitigate your risk. So in patients who are smokers, you do have a higher risk of respiratory illnesses, and that's why vaccines for respiratory illnesses are so important. So for us pertinent to the lungs, COVID-19 vaccination is recommended annually. Your influenza vaccine is recommended annually. If you're over the age of 60, your RSV vaccine is recommended, or if you're pregnant during RSV season, RSV vaccination is recommended as well. And then the pneumococcal vaccination is recommended for any sort of patient with lung disease age 50 or over. And then you get another dose after age 65. So, one huge strategy that we use in the clinics are when we have patients that have existing lung disease, existing heart disease, as a consequence of smoking, especially, we really encourage and the recommended guideline-based vaccination. This is a relatively newer, I think, modality of risk reduction or risk mitigation, lung cancer screening. So, like we talked about early on, patients who smoke are higher risk for lung cancer. And in the last 10 years, this idea of screening, just like you would screen for breast cancer in women, just like you would screen for colon cancer in any adult, you can also screen for lung cancer. And what this strategy allows us to do is potentially reduce mortality or death from lung cancer by 20% in patients who are screened versus patients who are not screened. So what does screening mean? If you fall in this age range, age 50 to 77, that's for CMS guidelines. General sort of commercial insurance extends that to age 80. So if you're between age 50 and 80, which is recommended by the US Preventative Services Task Force, and you have at least a 20-pack year smoke history. So you've smoked 1 pack a day for 20 years, or you smoked half a pack a day for longer than that. Any which way you do that math, if you've got a 20-pack year history, or if you currently smoke or quit within the past 15 years, you're eligible for a once a year low dose CT scan of your lungs. And really what you're doing by getting screened is you're checking to see if there's any early signs of cancer. And early signs of cancer in the lungs are small nodules. So if you were to find anything like that on your CT scan, you'd want to find it at an early stage rather than a late stage, because what we know is survival from an early stage lung cancer is excellent, and survival from a late stage cancer is not quite as excellent. And from the studies surrounding lung cancer screening, we have a decreased mortality of 20% compared to patients who are not screened. That's significantly better than colon cancer screening with a colonoscopy, and that's significantly better than breast cancer screening with a mammogram. So I think with that, I'll leave it for questions. What we went through in pretty rapid fire here was, what all of the tobacco products entail, the different types, the different mechanisms, some of the disease that are associated with it, and then emphasizing that it's never too late to quit smoking. It's never too late to try again to quit smoking. What the improvements in health can occur when you do quit smoking as soon as 12 hours after you quit, and then off other risk mitigation strategies such as respiratory vaccinations and screening for lung cancer.
Thank you so very much, Dr. Elahi. It was educational and informative. It brings me back to my early days working in a perinatal health network and doing quick counseling for pregnant teens at the time. And to see, where we were, gosh, decades ago and where we are today. It's scary to see those rates increasing. And, as a parent myself, and I know you yourself also have young children, and seeing the accessibility for these youth and the way in which things are being portrayed as no longer dangerous is very scary. The smell of it, smelling like a candle, or, mango flavored vapes, or and
Yeah,
it's
yeah.
not like, back in the day when your parents would smell something and say, well, why do you smell so bad? What is that? Is that cigarettes? Now everything smells pretty. And so it seems almost as though the industry has gone from, the days of where Joe Camel was banned and prohibited because it was enticing to youth, to circumventing and finding ways to target youth in particular. And so I guess the first question, and we did have a number of questions, and if others would like to ask, there is a Q&A option for you down below, or in the chat, however you feel comfortable. You can ask, and we'll ask Dr. Elahi on your behalf. But advice for parents on how to talk to your children, how to have these conversations, perhaps some, tips and tricks on what to be looking for.
Yeah, that's a great question. So you're right. I have two of my own, 11 and 9. My dad probably wouldn't want me to share this, but I grew up with a parent who was a smoker, and many of us who grew up in the 80s, that was actually the case. Um, but I I think the reason why we're putting on a webinar like this is so that there's initiation of dialogue. And I think one thing that my wife and I have encouraged in our family is just to have open dialogue and open communication about what risks there are out there. My son, who's just entered middle school, we worry daily about what type of things our children are exposed to. And when I study this, of course, and you see the data and the literature where middle school kids are exposed to this and are using this already, it makes me particularly more concerned. So there are, when I posted in that main page, the Campaign for Tobacco-Free Kids, it's a phenomenal resource because what they're working on is advocacy. They're trying to change policy that can affect how children are marketed towards by these tobacco industries. They also offer educational programs. So when you look at their website, there are educational opportunities for us to learn. And then there's also areas in there that allow our children to engage. So maybe encouraging our kids to become one of these advocacy spokespeople for tobacco-free kids, for example, to help them be aware and be champions to keep it in their circle that this is not something we want to be exposed to. So it's a very difficult question because it obviously it surrounds parenting and such, but I think we really need to be engaged and have open communication with our children. And that might be what's sort of perhaps a little different from the older generation to the newer generation, or perhaps a little more in tune. But as lives are so busy, oftentimes we just are present, but we may not be connected. And that's the part that we have to really repair, that connection.
Yeah, that's a wonderful answer, and I completely agree. There was a study done by Riley Children's Hospital of a very affluent high school in their area, nearby the hospital. And of the students that they surveyed, 80% of high school students had said that they had tried vape by the time they were surveyed. So you're right in that, targeting that middle school age is incredibly important, because by the time they reach high school, it may actually already be too late. There's also, Dr. Lahi, one of the other questions that I sort of wanted you to speak a little bit more to as well is you mentioned vape as being marketed as a safer alternative to cigarettes. I think we also see the same with hookah smoking as well too, right? So the pipe with the tobacco being filtered through water. I often hear, because this is cultural within our communities as well too, one of the things that I often hear people say, adults will, cite and say, well, there's no chemicals, and because it's being filtered through water, it's safe for me to do.
Yeah, I hear that a lot. And the issue surrounding a lot of these products is the inhalation of the flavorings and when you look at the materials that come out of it, the volatile organic compounds that are emitted from the vape itself, they actually are toxic. There are certainly some arguments where people will say these are cultural aspects, but despite being cultural aspects, they still impose health harm. So I don't think using the rationale of certain cultural habits as making it acceptable is a real sort of credible argument to use. And it's used frequently. I agree exactly with what you just said. I've heard that many times myself. But I think what's clear is God never had us intended to inhale smoke or chemicals or toxic products. And we know that there's adverse consequence to any of that, including hookah, despite it being quote unquote filtered through water. There's a smoke that's being inhaled and it's lined with chemicals that cause that flavor to be as enjoyable, quote unquote, as it is. It has harmful properties. And I think if you're truly conscientious about your health, those are really habits that you have to steer away from.
Two, I guess, more technical questions that have come up from the audience that I'd like to share. One is asking how to explain the difference between the mechanism of an inhaler. I don't know that we got into that in much detail, but how is it that the inhaler mechanism is different from a vape mechanism?
I don't understand the question. Inhaler means,
So the inhalers that are being used to quit smoking, the nicotine inhalers.
yes, understood. So, oh yes, and that was part of your question that some people are using vaping or hookah as their way of sort of getting away from smoking. And I encounter that almost daily from my patients. Now, there is data that shows patients who use an e-cigarette or a vape in a sort of strategic manner are able to successfully quit smoking cigarettes. There is data that supports that. There are certain thoughts that e-cigarette is a lesser evil than smoking a cigarette. So that's the other sort of thought process, which is a lesser of two evils. I think we've heard that a lot in our political spectrum. We've all kind of cringed when we heard that. And that's what I hear when people say, I'm doing the lesser of two evils. Now, I always am encouraged if a patient can transition from smoking cigarettes to a vape to nothing. So if it successfully allows them to wean off nicotine, which is what these devices can deliver, and that's what we're dependent on when you are a heavy smoker, you become dependent on that nicotine. So if you're using your e-cigarette or vape device as a means to wean yourself from that chemical dependency, I consider that a victory. But if you're replacing one vice with another, unfortunately, that's just replacing one harmful item with perhaps a quote unquote lesser harmful item.
Wonderful. Thank you for that answer. I appreciate that. I have one more technical question from the audience, and then after that, I have a personal question, and then we'll wrap up for the evening, if that's okay with you.
Mm-hmm.
Okay. So this provider is asking whether or not there are equivalencies or charts that allow providers, the chart that you shared earlier, the one with the 20 packs per pack calculation. It seems as though within healthcare, we're still calculating based on number of cigarettes or number of packs. But with these new devices, such as vapes or hookahs or whatever else it is, the e-cigarettes, for example, there's no start and stop to a cigarette. There are obviously the cartridges or whatever insertion liquid is being smoked. But how can providers make calculations on whether or not individuals will qualify for screening, or have we not yet reached that point?
Yes, so screening, lung cancer screening, unfortunately, only is covered for smoking cigarettes or cigars. So there are calculations that convert cigar usage, either a full-size cigar or a cigarillo, into how many cigarettes that would be. But from e-cigarette to vape, those patients are not in the same category for eligibility for lung cancer screening. Now, when I have patients that use these devices, I do ask them for the specific type, and I do ask them specifically if they're nicotine containing, what dose it is. Because oftentimes they are aware of that, and then the replacement modules can sometimes come in varying doses. So sometimes patients are actually weaning themselves to the lower nicotine doses on their devices. The pack year calculation, just as you pointed out, it is for cigarettes. And so if you know anyone that has a smoking history, odds are they will hit that 20 pack year threshold. And if they're 50 and over, it's pretty easy to become eligible for lung cancer screening. Unfortunately, I think the number is 8 out of 10 eligible persons are not getting screened by this easy low dose CT scan. So 80% of people that are eligible for a lung cancer screening CT that could have such a huge mortality benefit are not getting screened. And I would venture to guess it's actually higher in our in our Muslim population.
Thank you for that as well, Dr. Elahi. That was very informative. I'd like to wrap up the evening. Perhaps, we've talked a lot about of don't, and all wonderful advice, but thought to end this on a positive note. I wanted to know from you whether or not you had any success stories that you could share that perhaps have resonated with you throughout the years.
I have patients every day who say, Dr. Elahi, you never smoked. What do you know about quitting? And I go back to my childhood, and I remember my dad smoking a pack a day. And I remember how stubborn he was about quitting. And I forgot exactly how old I was, but there was a moment in time when he had a health scare, and all of us kids got on him to quit smoking, that he finally did. And if you guys know any, desi parent, the level of stubbornness in a desi dad is, it's essentially off the charts. And so I tell my patients, I smile and I share with them that if my father was able to quit smoking, I have complete faith in anyone else being able to quit smoking. So I share that with them in jest, but I share that as a sort of real life story as well, because I truly believe that the fact that my father was able to quit smoking really proves to me that anyone, no matter what degree of dependence, what degree of amount they're smoking, what degree of stubbornness they have, there's potential for them to quit. But there's this first step that occurs within all of our minds about when we want to impose a change. And when you cross that threshold that says, I need to make a change in my life, that is when your path opens up.
Alhamdulillah, a beautiful story to conclude the evening. Dr. Elahi, thank you so very much for your time once again. We so very much appreciate you and everything that you've done to educate us and inform us and have us be healthier as individuals. For those that are watching this evening, the session is being recorded. It will take us a few days to get this up on our YouTube channel, but if you'd like to review any of the content or information that Dr. Elahi has shared, it will be available to you shortly. Thank you all so much and have a wonderful evening.